is a great honor to have this title, Scientist Emeritus. For the Eye Institute, there are only 2 or 3, so I'm very, very honored. And it's my great privilege to speak here. This is the first time I come to the neuroimmunology. I usually go to an eye meeting, but I'm doing something that's neuroimmunology really related, especially now we're doing the research on age-related macular degeneration, and mainly I will present our work. If you can get the light dim, would be good. Thank you. AMD was first described as symmetrical central choroidal disease occurring in senile person by Hutchinson and Tay in 1875. However, people nowadays do not like to hear senile associated with aging. So the name was changed to age-related macular degeneration. That happened when I was fellowship, and I still remember we used to call it senile macular degeneration. AMD is a leading cause of irreversible central vision loss and blindness among the elderly in the world. The etiology is not exactly clear yet, and it involves multiple factors, such as aging, of course, that's how the name is, genetic predisposition, environmental element like smoking, diet, lipid metabolism, cell death, oxidative stress, and inflammation. Here I'm going to present the association with aging, cell death, and inflammation. AMD can be viewed as producing dysregulation and dysfunction of homeostasis processing that change throughout the age. As you can see that the fundus exam show you the age AMD. I don't see pointer here. We consider that this one?
Yeah.
Where
the very
is
top button.
this one?
Yes, ma'am.
Maybe if you get
That's
this.
the very top button.
Thank you. So if we look at the eye, and because it's inflammation related, so I have the cell, particularly like microglial cell and macrophage, M1 or M2 there. And the eye is neuroretina, that's most important. And the RPE cell is a retinal pigment epithelial cell, which is arises from neurocrest. And beneath that is Bruch's membrane and choroid. The choroid capillary will have a lot of blood supply. And the retina is sort of like brain, it's a blood brain barrier, or we call blood retina barrier, and the blood vessel mainly is in the inner neuroretina, or on here, 1/3 the place. And so when you get older, you can see that the homeostasis is still there, but it's going to have allostasis because the retina, the photoreceptor, they shut out the outer segment, and here it need to digest by the RPE cell, as you see. And when you get old, you may not as function as young, but so the microglial cell probably try to go down to help out to clean out those debris that the normal cannot clean so well as agent. And also the macrophage probably also come from the choroid that help to clean out for those debris to clean out. And if you have smoking or exposed more UV light, you may have more those photoreceptor debris, and you would accumulate in the RPE cell, had the lipofuscin, and you may create a problem. But when allostatus still can function, And it is important to have local information, and that related to the AMD. I like this very much. It's from Anderson, they review, and 7 years prior to 2010, they had another review, and they showed that how important the photo information, local information is to clear out those debris. And there's inflammatory cascade they are involved. Me as an ocular pathologist, I'm more interested to look at inflammatory cell that including macrophage, microglia, which I already showed you earlier, the cartoon picture there, and also had lymphocyte. And this inflammatory cell, they can release inflammatory factors such as complement factor, inflammasome, and cytokine. And here I'm going to present to you in our work, so it involves IL-1 beta, IL-18, and IL-17. Of course, this cytokine are related to inflammasome. So I show you that I talk about macrophage. It's important in the AMD because when aging, they probably come to help to clean out the junk or debris for the RPE cell. But it is important to know AMD is not a classical inflammatory disease like uveitis. However, you can see the inflammatory cell, especially the macrophage, in the AMD lesions. Macrophage can secrete different cytokine, chemokine, and growth factor, so all these are implicated in AMD. Here, as early as 1985, Penfer et al. From Australia, they already demonstrate a circle there, the macrophage, and also you can see L is lymphocyte in the AMD lesion where the Bruch's membrane is. My mentor, Dr. Green at Johns Hopkins Wilmer Institute, not only showed macrophage, but even showed the giant cell macrophage in the where AMD lesion is. We and others, we show that CD68 is macrophage marker and also in the AMD lesion. Hans Gosnikowska et al., they look at 143 sample of AMD and they noticed that there was very major component is the macrophage there. And you can pay attention, the central macrophage is much more than the peripheral macrophage because macula is in the central, so that's where the lesion is. We know nowadays that the macrophage are easily polarized. They can subdivide two major classes. One is M1, which is classical activated macrophage. This macrophage can produce pro-inflammatory and get tissue damage. However, they are anti-angiogenesis. In the contrast, M2 is alternative activated macrophage. They help tissue remodeling, angiogenesis, also fibrosis. It is important to note there are other classifications as well, also the M1 and M2 are very easy to convert depending on microenvironment. They're not like T cell when Th1 or Th2, they're pretty stable in the tissue and not change subtype. Yet macrophage, they do change, so you have to really pay attention. And Ferguson and Abe, they look at mouse, and when they look at the young mouse macrophage and compare to the old mouse macrophage, you can see that the young mouse macrophage more M1 and the old more M2. Xiaoguang Chao in my lab, when was postdoc fellow there, he looked at macrophage. We looked some AMD lesion, and as you know, the number is small, but it's humanized, so sometimes it's difficult to get it. And when you see it, the M1 and M2, we take out the macular area and do the study, and we can see that there was shift. It seems MEM1 shift more on the M2. So the ratio for the AMD, the M1 is less, M2 is higher. Here is how we did it. And we take out the lesion by microdissection as the AMD lesion here, or here the neovascular AMD. And then we examine, and that's what we see. Here is immunohistochemistry, and you can see that in the AMD lesion, again, for the dry AMD, the top panel, you can see it seems M1 probably a little bit higher, yet the wet AMD CD163 more potent for M2 marker and have more. And you can think that for wet AMD, it's neovascular AMD, which I forgot to mention earlier. For pathology or clinical, there are two types of AMD. One is dry, it's just cell death without neovascularization. The other one is wet, it's choroidal neovascularization. As you see, the choroid vessel break down and get the choroid neovascularization, and they become neovascular AMD. So they have more M2, which earlier I mentioned M2 is more angiogenesis and M1 is more tissue destruction. So probably that fits the dry and wet AMD. And we know that macrophage are second most major site of complement synthesis, second to liver. And the complement had many functions. One is very important was the chemotaxis. So we cool and retract even more inflammatory cell to the side, as you see from this cartoon. And Dr. Chu in our lab, and he reviewed and find out that, in fact, it's all reported. AMD is very close related to immune gene. One is very important was the complement factors. And complement and inflammasome, we go on, is very important because that can rise inflammasome, particularly when you have calcium too. In fact, complement can elicit secretion of IL-1 beta and IL-18 through NLRP3 inflammasome. So what is inflammasome? Inflammasome is a multiple protein complex, as shown the diagram here, and it can recognize information-induced stimuli, including PAM and also THAM. And THAM is important because in AMD, a lot of neurogenesis, neurodegenerative disease, that it has damage-associated molecule pattern, and it perpetuates the tissue homeostasis, as you recall earlier, the AMD, before the normal eye retina, they had homeostasis or allostasis in the old age. So this is probably it is a disease of allostasis overload there. And when we had this inflammasome combined, and particularly here NLRP3, and they can get the when you get the activated caspase 1 and you get IL-1 beta or IL-18 to release to mature IL-1 beta and IL-18. So the role recently has shown that inflammasome is very close related to other diseases such as diabetes, obesity, atherosclerosis, gout, and AMD as well. And Barty's group, they published that there is inflammasome deposit in the AMD lesion, as you see here, including NLRP3, caspase 1, and also Buscasena's group, they also show that, as you see here, the NLRP3 is positive deposit in the lesion of AMD, both geographic dry AMD and neovascular wet AMD. we take some samples, same thing as I show you, do the macrophage marker. Same thing when we take it and look at, and again, we see significant higher NLRP3, IL-1 beta, and IL-18 in AMD macular lesion. That was done by Dr. Fan Sen in the lab. Yu Juan Wang, she looked at in